late, so we'll start the session with our first speaker. So it is just a session on vascular, inflammatory and infective disorders, but it is a potpourri of things. So we'll start with the first interesting case, that is sound-induced subhyaloid hemorrhage. Right? Yeah. In the meantime, I request Dr. Rajvinder to please grace the stage.
A very good afternoon, everyone. Today I am here with two separate cases of subhyaloid hemorrhage in two young lads who presented with subhyaloid bleed following attending a festivity with very large, very loud DJ sound for a prolonged period of time. The first case is of a 16-year-old who had sudden loss of vision following the same case, that is loud sound exposure. The vision was hand movements. There was no history of any trauma or systemic illness. This was the fundus picture, where we can see a large subhyaloid bleed about 3 disc diameter in size, which has the typical double ring appearance along with the exclamation mark. On doing serial OCT, we were able to discern the site of the bleed that was subhyaloid in nature. Because it was a very fresh bleed, we opted for an NDAG hyaloidectomy away from the macula, which led to immediate draining of blood inferiorly. This was the status of the patient post 1 month. We can see the empty cavity along with some inner retinal layer damage as well because of the strong laser. The vision was good. It was 6/6 in right eye. Case 2 is of a 20-year-old presented with similar history. The best corrected vision was 1/60. We treated the patient with C3 F8 and face down positioning. But 1 week later, the patient had dispersed hemorrhage with only PL plus vision. We wanted the patient to have a good vision earlier, so we went for an vitrectomy. This was the post-op picture. There were some irregularities of the inner retinal layers, which is seen 7 days post-op. Post 1 month and post 2nd month, the retinal anatomy was well restored. Now, putting on a thinking cap, we thought what could be the other cause in this case. There was no history of any Valsalva or any breathing disorder, breathing exercises being done. The cardiology evaluation came out to be normal. There were no bleeding disorder, no history of any trauma, and no other retinal disorder in the same eye or in the other eye as well. Only questions remain, could it be a case of a laser light retinopathy? But then again, why only 1 case per event? And then also, many people should have been affected if it was due to a faulty laser. The patient also agreed that there was no laser light involved in the festivity. Now, normal conversation is around 60 decibels, traffic sounds are 80 decibels, but very large loud sound at a rock concert or such DJ sounds at a festivity, it will be around 120 to 140 decibel. So I believe that this could be due to a one-time exposure to an intense impulse sound. High decibels can cause a transient high blood pressure, leading to a vascular blowout. Secondary to this, intravascular pressure rise. There have been reports of subhyaloid hemorrhage when there was accidental exposure of laser light, where 34 eyes were simultaneously affected. Indian festivities rely heavily on this loud music and laser sounds, but reports on any loud sound causing a vascular damage, like a subhyaloid bleed, is missing. There have been reports of stroke and CVA caused due to loud traffic sounds. Such incidents need reporting to determine the safe limits of how much sound we can expose ourselves, the distance we can keep from the sound box, and the time period for which such kind of exposure can lead to such bleeds. Aberrant use of recreational lasers and high decibel sounds need monitoring, public awareness, as well as government regulations. Thank you.
Nice. Thank you for doing it within the allotted time. So we can go to the audience if they have any doubts. Anybody wants to ask any question to the speaker? So I had a few doubts to ask you in the meantime. So first thing you said, it is sound related. And second, we are going to say that it is a subhyaloid hemorrhage. So do you think it was the same case for the second case? The sound could lead to a bleed just at the fovea.
So we had that because the patient gave the same kind of history that the night before they had attended a barat with a very loud music, and they agreed that they were standing very close to the sound box for about 2 to 3 hours.
Okay. And were there no history of laser light exposure at the events?
They were saying no. And
Okay.
I also found out from government regulations that they cannot use the damaging laser light at the festivity. But again, the case report that I had shown that 34 eyes were affected,
Yeah.
the laser light component was affected in that case.
Yeah, because all the previous reports, they said it was due to a laser light shining in the eye. The patients reported a sudden flash and a blackout, followed by when they went to the ophthalmologist, they had these bleeds. So it might be related more to the laser light exposure than to the sound. The second instance, the subhyaloid hemorrhage, are you sure about the location of it? Because in the second case, it was looking
like a
sub-ILM.
sub-ILM bleed, yes.
And in the first case, there were other signs to also indicate the sub-ILM
Sub-ILM.
location.
Actually, the exclamation mark and double ring sign.
Yeah.
But when I did the serial OCT, it was like the retinal layers are all intact, and above that, the subhyaloid bleed.
Yeah, so it is very difficult to make out whether you are in the sub-ILM space or whether it is the subhyaloid space.
I read
So
a
on-
lot of papers for that, but
Yeah, so on
it's
the
very
OCT,
confusing
what you
actually.
can do is try to trace whether you can see the posterior hyaloid. If you are seeing the hyaloid as well as the ILM as a two layer, that is also known as a double layer
Yeah, so these
sign.
young age patients, hyaloid visibility was very difficult
Yeah,
because
true, I agree with you. But it might be a case of more of sub-ILM hemorrhage because not all boat-shaped bleeds are sub-hyaloid. So these sub-ILM hemorrhages, you can inadvertently go and hit the laser thinking that it's the posterior hyaloid, but you might damage the underlying retina. Whereas it was safe in this case, no issues occurred, but you have to be careful in the next cases.
thank you.
Dr. Raju. So in the meantime, I call upon the stage the second speaker for the day. She'll be talking about an interesting case of unilateral central retinal artery occlusion in young adult. Dr. Sakshi Kumar.
Good afternoon, everyone. Today, I am going to present an interesting case of unilateral central retinal artery occlusion in a young adult. A 20-year-old male came to us with the complaints of loss of vision from past 1 week. There was no history of any floaters, flashes of light, any curtain falling sensation, any strenuous coughing or intense vomiting or headache. Patient was apparently asymptomatic 1 week back when he developed a loss of vision which was painless, sudden in onset and gradual in progression. He had no systemic illness. On performing general examination, he was moderately built and there were no signs of any cyanosis, pallor or icterus, and his vitals were also within normal limits. On performing the ocular examination, the vision in his left eye was perception of light was negative. There was a relative afferent pupillary defect of grade 3. On performing a fundus evaluation, there was blurring of disc margin with pale retina suggestive of retinal edema and cherry red spot at the macula. This was the fundus picture at the time of presentation, suggestive of pale retina in the left eye. A diagnosis of left central retinal arterial occlusion was made clinically. Investigations were ordered to rule out the cause, as this entity is very uncommon in young patients. Basic investigations were performed, which included CBC-ESR, serum homocysteine, ANA, PT-INR, and patient was found to be diagnosed with hyperhomocysteinemia, as his serum homocysteine level was raised and found to be 23.35 micromoles per liter. In such patients, there is often risk of cardiovascular disorders. There is risk of thromboembolic events which can lead to stroke. There can also be chances of carotid artery stenosis, hence an ECG, an MRI and carotid Doppler was performed, which was found to be within normal limits. Patient was started on antiplatelet, methylcobalamin and folic acid combination and statin, and the level of homocysteine came to normal of about 10.5 micromoles per liter after 1 month of therapy. This was his fundus picture at 1 month, though the patient developed complete atrophy, but we were able to prevent certain events which could be life-threatening. This was his optical coherence tomography at 1 month, which showed thinning, RNFL thinning much below the normal limits. Also, there was thinning in the macular region. What can be the presentations of hyperhomocystinemia? There can be retinal arterial occlusions, vein occlusions, thromboembolic events. In patients with cardiac abnormalities, this condition is found. It can also lead to schizophrenia, hip fractures, osteoporosis, and Alzheimer's disease. So, the take-home message for us is central retinal arterial occlusion, though very rare, can occur in young adults. Most common causes can be any cardiac abnormality like valve defects or metabolic disorders like raised homocysteine. An echocardiogram and echocardiography should be performed to rule out any cardiac abnormalities. A magnetic resonance imaging should be done to rule out any risk of stroke. Carotid Doppler should be performed to rule out the stenosis of carotid artery, and all the above investigations are done to rule out any life-threatening complication, and the treatment should also be given immediately to control the levels of homocysteine. Thank you.
And thank you for that case presentation. Any questions from the panelists or from the audience?
What is the incidence of venous occlusion, and what is the incidence of arterial occlusion in patients with hyperhomocystinemia?
Sir, the incidence of arterial occlusion is very rare, sir. It is about 0.02% in 1 lakh patients, sir. Whereas in venous occlusion is about 1 to 2% in 1 lakh patients, sir.
Any other question from the audience? So I had one question to ask you. So was the complete cardiologist workup done, and did they find any abnormality in that?
Sir, in this patient, in echocardiography, there were some signs of LVH, left ventricular hypertrophy, but since it is somewhat common finding in young adults, so I did not mention. But again, I would like to emphasize that LVH and association of central retinal artery occlusion has been found in some studies.
Okay. LVH?
Left ventricular hypertrophy.
Left ventricular hypertrophy can occur in hypertensive patients. So how do you explain? How do you explain association of LVH with this arterial occlusion? Because LVH is a common finding wherever you have
that's why ventricular
overload because of hypertension, you will have left ventricular hypertrophy. So how do you explain this association?
Sir, I found it in some studies that in some patients...
That may be because of hypertension. I think hypertension leading to LVH, it was so association between hypertension and occlusion, but not LVH and SVH, because LVH is effect of hypertension. Okay.
Thanks.
Carotid Doppler was done in this case?
Yes, sir. Yes, ma'am.
Okay. So I call upon to the stage the next speaker. Dr. Utkarsh is not here, so when vomiting takes a visual toll, Dr. Swain Ankita.
Good afternoon, everyone. So let's start with the case. When vomiting takes a visual toll, a diagnostic challenge of sudden vision loss. A 30-year-old male of upper middle socioeconomic status came to the clinic with sudden painless diminution of vision in both eyes since one day. He had a past history of 3 episodes of severe vomiting along with retching 1 day back, followed by sudden painless loss of vision in both eyes, and patient is a known chronic alcoholic. So patient was apparently all right 1 day back, after which he developed sudden painless loss of vision preceded by 3 episodes of severe vomiting. No systemic history of diabetes, hypertension, blood dyscrasias, viral infection or trauma. On general examination, all the vitals were within the normal limits. Systemic examination, all the systems were within the normal limits. So on ocular examination, right eye, left eye showed counting fingers and less than N36 in both uncorrected and best corrected visual acuity, and all the anterior segment findings were within the normal limits. On fundus examination, showed hazy media, 0.3 cup disc ratio, healthy optic disc, and dull foveal reflex and subhyaloid hemorrhage in macula in both. So this is the fundus photography of right and left eye, which shows boat-shaped hemorrhage, boat-shaped subhyaloid hemorrhage, symmetrical hemorrhage in both right and left eye. So to summarize my case with, a 30-year-old male presented to the clinic with sudden painless diminution of vision in both eyes since one day, preceded by 3 episodes of severe vomiting along with retching. Patient is a known chronic alcoholic with positive findings of bilateral subhyaloid hemorrhage on fundus examination. So my provisional diagnosis is bilateral symmetrical subhyaloid hemorrhage sequelae of valsalva retinopathy. YAG halitotomy was tried, but it failed, so we went with pars plana vitrectomy, left eye followed by right eye. And this is the 2-month post-operative vision. The best uncorrected visual acuity was 618 N6 in right eye and 612 parts N6 in left eye, and the best corrected visual acuity was 66 N6 in both right and left eye. So this is the post-vitrectomy OCT of right eye and left eye respectively. So my take-home message is: 1, violent vomit can steal the view. Forceful vomiting can induce a valsalva maneuver, abruptly raising the retinal venous pressure and rupturing the superficial retinal vessels, leading to subhyaloid hemorrhage and abrupt painless loss of vision. So prompt ophthalmic evaluation, appropriate monitoring and timely intervention is key to protect sight. So this is it. Thank you.
Okay, so you finished well within time, and you showed us a case of vomiting followed by bilateral subhyaloid hemorrhages.
Symmetrical.
Symmetrical. So can you provide more information about 2 things? Why did the hyalodotomy, as was done, failed, and what was done in the pars plana vitrectomy?
Sir, maybe there was a denser, it was a fresh bleeding, but it was too dense, so the hyalodotomy failed. We tried it, but it failed. So we have to go with pars plana vitrectomy.
So what was done exactly in the pars plana vitrectomy? Did the bleed come initially, or did you have to do an ILM peel also?
So we have to do the ILM peeling, and then we went for the bleed.
So if you had to do the ILM peel, that means the blood was sub-ILM and not sub-hyaloid, right?
Yes, sir.
Yeah, so that is a point to be noted,
yes.
because there were some signs in the fundus photo.
Yes.
If we can have that
Yes.
slide up, so you can see that there is a double ring sign.
Doubling.
So
Outer
that
one is
shows
full.
that a flaky hemorrhages that are surrounding a
Can you show that
central
again?
bleed.
Sir, they have changed the slide.
Can we have that presentation up on the screen?
Presentation
Last
again?
presentation again. Yeah. So that is one sign, and along with that there is a recently described sign. You must have known about arcus senilis. There is
Yes.
arcus retinalis also. So if you see a white line
It
that
is
is
exactly
bordering
like
the
this.
hemorrhage, so that is an indicator of sub-ILM hemorrhage. So that one should be on the lookout for.
Yes.
Yeah, so if you can see around the hemorrhages, just inferior to the hemorrhage border, there is a slight whitish line that is
Yes,
going
yes.
all around it. So that is a ring, that is the arcus retinalis. And if you can see some signs on top of the hemorrhage, there's a glistening light reflex, small to a comma or an apostrophe shape. And what I was referring to as the double ring sign, you can see a ring of flaky hemorrhages all around. So that is actually in the subhyaloid space,
Subhyaloid space.
and the inner bleed is sub-ILM.
Sub-ILM space.
So you have to be careful while doing the hyalodotomy, because
Yes.
what we use is a 1064 nanometer hyalod ND-YAG laser to pierce the hyalod, but that leads to a damage onto the retina. So
Yes.
if you go ahead to the OCT in the left eye, there is
Yes,
an
there
interesting
a
finding.
Lamellar hole. Yeah. Yes. Which was found out later after doing the OCT. In the left eye, there is a lamellar hole.
There is a lamellar.
Yeah, so
So-
that is unexpected, and that
Yes.
has resulted.
Since the patient is 6'6", so we have kept under observation for now, and we are following up.
So probably a primary vitrectomy in the next time, just with the ILM peel, would have avoided this kind
This
of a
one.
thing. Any question from the panelists? Any question from the audience? Thank you for the nice case. So in the interest of time, we'll move on to the next case. Sequential visual losses, initial symptoms presenting before cutaneous manifestation of SLE. Dr. Achetanya Y.V. Krishna.
Good afternoon, respected members of the panel and dear colleagues. My patient is a 30-year-old woman who presented to us with chief complaints of loss of vision in her right eye for 1 month duration. The history dated back a month back, when at the onset she had pain and vomiting, and 10 days later she consulted elsewhere with the vision as documented, but the right eye diminution of vision progressed further, and when she came to us, she had a PL negative vision with RAPD and no other significant findings in the anterior segment. On fundus examination, there were patches of retinal opacification and multiple dot blot hemorrhages in the right eye, while left eye was essentially normal with mild tortuosity of vessels, some sheathing in the superior peripheral vessels, and a cotton wool spot. An angiography was performed which showed marked areas of capillary non-perfusion. There was macular ischemia and diffuse vascular leak, predominantly involving the veins in the right eye, while the left eye was within normal limits. The right eye OCT showed PAM, macular edema, and subfoveal fluid, while the left eye was normal at this point. Occlusive retinal vasculitis, right eye was diagnosed and prophylactic PRP was performed. Immunosuppressant tablet prednisolone was started. A rheumatology consult was also sought with the following labs, but the patient came back to us 2 weeks later. She was lost to follow up in the meantime with a profound loss of vision in the left eye as well. We performed a general systemic examination which was found to be fairly within normal limits, and now she had a denied PL vision in both eyes. RAPD continued to persist in the right eye. We have a right eye with occlusive retinal vasculitis well lasered, while the left eye continued to show essentially normal findings. OCT in the right eye showed resolving features of the earlier features, while left eye continued to show normal findings. Fluorescein angiography with this time more focus on the left eye was performed, and we noted a delayed filling of arteries which showed at 17 seconds, and arterial filling was more delayed in the inferior arcade as compared to the superior arcade. Rest of the findings were essentially normal. This was a bilateral sequential complete loss of vision. The patient was admitted and started on IV methylprednisolone, and a neurological consultation was also sought. In the meantime, investigations were performed. The hematology biochemistry was essentially normal. However, ESR, CRP were significantly raised, and ANA was positive at 1:160 titers. Rheumatology consultation, a thorough examination revealed no systemic features of connective tissue disease, so they advised us to continue what we were doing, and some additional investigations were ordered which also turned up negative. A neurological consultation ordered a thorough imaging including carotid Doppler which was normal, while a CSF analysis revealed a higher than an opening pressure which was towards the higher range of normal, and therefore tablet acetazolamide and certain couple of therapeutic lumbar punctures were ordered. However, CSF analysis was essentially normal. So the course in the hospital in the left eye started showing improvement after each therapeutic tap and IVMP that we did. And at this point, we considered a diagnosis of idiopathic intracranial hypertension without papilledema, which is an extremely rare, however, a reported condition in the left eye. On day 10 of admission, the vision in both eyes had started improving. The right eye has also improved gradually to counting fingers, with the fundus findings remaining the same. As the vision in the left eye improved to 6/9, we performed a visual field also, which had a doubtful reliability but showed intact fields. And 6 months later, while the patient was consistently being followed up, the patient suddenly manifested erythematous cutaneous maculopapular rash involving the malar region and the back. We dug deeper and found anti-Smith and SSA antibodies to be positive. This was a bilateral sequential vision loss secondary to SLE. The patient is still under regular follow-up, started on hydroxychloroquine. Cases with diagnostic dilemma like this need to be dealt with an aggressive and a multidisciplinary approach. Thank you.
And thank you for that very interesting case. So I'll go to the panelists if they have any questions.
MRI was done in this case? MRI?
Yes, ma'am. Contrast enhanced MRI as well as MR angiography. As we were at our wits end, what is happening, we did go, and this was all with the neurological team in picture.
Okay.
And it was normal, ma'am.
Normal. So then the neurologist opinion for CSF, as you have labeled that benign intracranial hypertension.
Ma'am, so like I said, it wasn't grossly high, the opening pressure, but it was higher than the upper limit of normal range. And therefore, because of the symptomatic status of the patient and because of certain other clinical clues with the neurological team found, her general body built, her general emotional state, they leaned towards the diagnosis of IIH and went ahead with the acetazolamide, which they continued for 3 months.
But that 3 months course of acetazolamide did not help. It did not help. No?
Sir, the acetazolamide?
Yeah.
Sir, we believe that the acetazolamide as well as therapeutic lumbar puncture did play a role in her improvement of the left eye condition.
Okay. And how has been the course on hydroxychloroquine, which has been started?
Sir, she's still on. It has been continuing 300
What is the
mg
visual
twice a day.
status? What is the visual status now?
Sir, so in the right eye, the one with occlusive vasculitis, she's counting fingers. and in the left eye it has improved to 6/9.
6/9.
Okay, so any other question from the audience? I had one question for you. So I have a bit doubt about the right eye diagnosis. So you said it is PAM and the patient was denies PL. So how do the two tie in?
It was hard to correlate, sir. That is why we went all in with the treatment. We did PRP right at the first sitting. It was measured. I did the vision myself with an indirect in a dark room. It was denied PL, sir.
Yeah, so I can agree with that the patient was PL negative. But the important point is, when did you see the patient after the symptoms began?
Correct,
So
sir.
it is most likely a central retinal artery occlusion that has occurred because you see patchy areas of CNP loss that was there. That led you to do the PRP later on, not the PAM. And initially, it might even have been an ophthalmic artery occlusion
Ophthalmic
because of the inflammation. Because normally your PL is preserved in central retinal artery occlusions,
Absolutely,
right? So you might have been seeing it at a later stage when the artery has opened up, and that is why you see manifestation on OCT looking like PAM. But in the initial stage, it would have been a complete whiteout.
Absolutely.
That
sir.
explains. So we can move on to the next stage. Thank you for that.
Who's the next? Now we have Dr. Pooja Sinha.
Dr. Pooja Sinha.
Dr. Pooja Sinha is going to talk on a curious case of fever and retinitis. Dr. Pooja Sinha is a renowned vitreoretinal surgeon from Patna, and she is has very popular instruction courses always at AIOS.
Thank you very much, sir. I feel so humbled. And I'm truly thankful to AIOS and the organizing committee for giving me this opportunity. I'll be presenting a very interesting case that I encountered. This was a 24-year male patient who complained of diminution of vision in both eye, left eye more than right eye, of 15 days duration. He had a history of fever with severe headache 1 month ago. The fever had subsided now, but since the vision was very poor, he came to me for a checkup. Vision in the right eye was counting finger 6/6, while in the left eye it was markedly reduced and it was counting finger of half meters. This was the clinical fundus picture of both eyes. There were multiple cotton wool spots all around the peripapillary area and in the left eye also along the arcades, indicating the level of ischemia. Along with that, there were some hemorrhages. So this was the OCT picture which showed some amount of inner retinal thickening along with subretinal fluid spaces. And this was the left eye. There was a marked subretinal as well as intraretinal fluid along with retinal thickening that was noted. And this was the FFA picture which showed this lacy hyperfluorescence network all along the disc. So I investigated him. The BP was normal. Sugar was also all right. The Vidal test, Salmonella typhi A was reactive, and the rest of the tests all were non-reactive, as you can see. So I made a diagnosis of post-fever retinitis secondary to typhoid. The patient was started on systemic steroids, starting with 50 milligram per day in a weekly tapering doses. Along with that, I added oral ciprofloxacin 500 milligram BD for 5 days. After 15 days, the patient reported to me where the vision in the right eye had reduced a little to 6/18, and the left eye was only marginally improved to counting finger 4 meters at this time. So this was after 15 days of starting systemic steroids. You can see that the cotton wool spots such as retinitis lesions in the peripapillary area had increased, and there was a macular fan also in the left eye especially, suggesting of resolving macular edema. And this was the OCT picture on follow-up. This was the thickening of the inner retinal layers which had increased, and shadowing and minimal subretinal fluid. And this is in the left eye. Though the fluid had decreased a little, the thickening of the retina was very much evident. And this was the FFA picture on follow-up. And at this stage, there were marked CNP areas, capillary non-perfusion areas, all along the arcades and also in the peripapillary area. So since there was a lot of ischemia, I thought to myself that let's give injection ranibizumab, and an anti-VEGF agent should be given because the VEGF load in this vitreous cavity of these patients is definitely very high. So this was given in the left eye followed by right eye after 1 week, and this was 15 days after the first injection. And this was the right eye. You can see the cotton wool spots were there. This is both eyes put together. The macular edema and fan was evident because the fluid was subsiding very quickly, but the cotton wool spots were still remaining. And though the OCT picture looked still very presentable, the fluid had come down, the foveal contour was more or less maintained, the vision did not do pretty much okay. And this was the left eye. You can see that post anti-VEGF injection, the fluid had resolved and the foveal contour had regained. And this was the OCTA, not much of ischemia I could note at this stage. So just to discuss, post-fever retinitis is an infectious or a para-infectious uveitic entity caused by bacterial or viral agents. Usually occurs in the 3rd week after onset of typhoid fever. This is referred to as the week of complications. Typhoid retinitis may occur secondary to direct invasion of Salmonella typhi or an immune-mediated reaction. In most cases, fundus lesions resolve, leaving a pigment epithelial change and foveal thinning. In post-fever retinitis owing to typhoid, sometimes the everything all is well that ends well. But in my case, the vision was very poor because maybe the papillitis lesions were sitting directly on the papillomacular bundle. Thank you so much for your kind attention.
Thank you for that nice case. I'd go to the panelists for their views.
So, normally these days we start some other fluoroquinolone, higher fluoroquinolone, but this was treated on ciprofloxacin and along with high dose of steroids.
So I feel the infective element had reduced. This was a kind of an inflammatory element and an immune-mediated reaction which was predominant in this patient's eyes. And his fever had also subsided since 1 month. His medicines for typhoid had also, the doctor had ceased those. I mean, he had finished the course with the physician. So now the eye sequelae was more of an immune-mediated reaction, which I thought was there. But still, I added the antibiotic. But I feel that this ischemia played a major role in my case, and also that the lesions were sitting on the papillomacular bundle. Although in these cases, the visual acuity is very good most of the times.
Do you think instead of giving systemic steroids, we can think of giving anti-VEGF or intravitreal steroids at that acute stage?
So I gave anti-VEGF injections.
After systemic steroid?
Yes.
Okay.
Actually, in such cases, because there are infective pathology, we feel scared in giving bolus intravitreal steroids in these cases.
What other systemic investigations were done?
Everything else was done since we got this as a positive finding, we based our case only on typhoid retinitis.
Okay. If there are no more doubts, we can move to the next speaker. Thank you for that talk.
Thank you so much.
So now I call upon stage Dr. Bhanu Priya for a talk on dexamethasone implant in silicone oil filled eye. Can we have a slides, please?
A very good afternoon. Today I am talking about Ojidex implant in silicone oil filled eye. So as we know, silicone oil is the main choice of endotamponade in complicated VR surgeries, and there are macular edema cases after vitrectomy has been reported with an incidence of 5.5 to 47%. So macular edema in silicone oil is somewhat different because there is accumulation of cytokine and growth factors. Sorry. So there is accumulation of cytokine and growth factors in the retrosiliconous space, which contribute to severe and long-lasting macular edema. So the treatment options for macular edema is either NSAIDs, topical steroid, or intravitreal timeslow acetate. But in silicone oil filled eye, it will not be able to manage because silicone oil acts as a barrier for the therapeutic drug to reach the retina. So the other option is either removal of silicone oil, anti-VEGF injections, or dexamethasone implant to tackle the inflammation. So I am going to share about our cases. So this was a 33-year-old female with uncontrolled diabetes presented to us with bilateral PDR with right eye vitreous hemorrhage, and the vision was hand movement. On BA scan, there was tractional retinal detachment was noted. So we went ahead, did a VR surgery with silicone oil, 1000 century stroke. Patient was happy, but after 2 months of surgery, she developed macular edema and her vision dropped. So we went ahead and give Orjudex, and within 4 weeks, there was anatomical improvement, but functional improvement did not improve much, and the IOP was within normal range. So this second case of 58-year-old female with bilateral lizard PDR, there was history of multiple injections, and she presented with right eye vitreous hemorrhage, and the visual acuity was finger counting close to face. So we went ahead, did a surgery. She was maintaining visual acuity of 6/36, but after 2 months, she again developed macular edema, and she was very unhappy with the visual acuity of 6/60. So we went ahead and give her Orjudex. So after 2 months, she did improve with the resolution of macular edema, and the visual acuity also improved by 1 line. So in our case, say the macular edema appeared around 2 months of the VR surgeries. We used 1000 century stroke of silicone oil. There was resolution of macular edema, and there was improvement of visual acuity also. So, and we also did not noted any rise in intraocular pressure, but there is some thing they say that this Orjudex implant is given by the 22 gauge. So there is some cases reported with when they give the silicone, they give Orjudex, there is seepage of silicone oil in the some conjunctival space, but we did not see any sort of thing. So we thought the Dex implant can be used as a first line treatment for macular edema in silicone oil in situ eyes. There are very few articles who have highlighted this dexamethasone implant in macular edema under silicone oil. So this is the one article who have given silicone oil after there was persistent edema and despite using the topical NSAID and steroid treatment, they did use 5000 century stroke for the endotamponade, and they also concluded that dexamethasone implant can be used as a first line treatment, and there is no need for the early silicone removal because redetachment, resurgeries have more complications also. So dexamethasone implant behave very differently under silicone oil compared to the BSS. So there is this is another article which have highlighted the in vitro pharmacokinetics behavior of the dexamethasone under silicone oil, and which resulted that Orjudex in the 1000 century stroke have more inhibitory effect compared to the denser media. So the take home message is Orjudex implant is preferable alternative for macular edema under silicone oil field eye, especially in the diabetic cases where inflammation plays a very important role. Thank you so much.
Thank you for that very interesting case series. So, a question from the panelists?
What precaution we should take when to inject Orjudex in silicone oil filled eyes?
Ma'am,
so that there is no leakage.
Yes, ma'am. So first is the direction of the how you give the Orjudex implant, and other thing we should have an standby sutures also. If there is a silicone seepage, we must suture that port area. So we do not have that silicone seepage or post-op hypertonia also.
Okay, that's nice. One question I had for you. So we did not have any control group here to compare with. So we do not know what the natural history of such an edema is, whether it resolves on its own, whether the oil is the culprit here, maybe oil removal would have helped. So
yes, sir, we need more data on that. So we'll try to give more
details. Yeah, so it is
a
novel approach, and patients who can afford this implant, they can undergo it.
Since the first patient was 33-year-old engineer girl, she was very anxious. So we with bilateral PDR, so she was very anxious. So we must need to do something for these patients. And again, if there is one-eyed patient, if the better eye is there, so we need to do something. So the best vision we can give So we have to go
that
for
I
extra
understand.
length
Yeah.
in these cases.
So there is
Also.
another option that you could have tried a posterior subtenons. That is a high dose, and that also helps in such kind of a cystoid
Yes,
macular edema.
definitely. So this is another
And
option.
it
I will
might
try
be
to
more
do
cost effective,
in other
right?
cases also. Thank you so much.
Thank you.
Thank you, sir.
So for the next presenter, do we have Dr. Sonalika Gautam here? So we'll move on to the next one. Dr. Shyankshi Biswas will be talking about APMPP with optic nerve involvement.
Good afternoon, my respected chairpersons and delegates. Today I'm going to present a case report on acute posterior multifocal placoid pigment epitheliopathy with optic nerve involvement. Now the patient was of 26 years old male with a recent onset of viral fever and headache with sudden painless loss of vision. Systemic examination was all normal. His vision was right eye 6/6 and the other left eye was PL and PR. Pupil, there was RAPT in the left eye, and the anterior segment findings only that peripheral conjunctival redness was present in the left eye. On fundoscopy, the left eye showed the placoids at posterior pole involving the macula and with continuity around the disc, and plus disc edema was present. The right eye was all within normal limits. So this was the picture with left eye placoids. Now, this is the differential diagnosis which we can have with this picture, right? The APM-PPE, VKH, sympathetic ophthalmia, ocular lymphoma, metastasis, posterior scleritis, and placoid maculopathy, serpiginous choroidopathy, and sarcoidosis, TB syphilis. For that, we undergone numerous blood investigations, but the blood investigation, serum, ACE, and the cold quantiferin test were all negative, and VDRL test was also non-reactive. Mild lymphocytosis was there in CBC, and the chest X-ray, CT thorax was also unremarkable. Nothing was found. The MRI was also done, and MRI showed only optic nerve head edema and nothing else. So my next investigations goes for the ocular part. So in the ocular part, what we have seen that the DFA showed that there was early hypofluorescence followed by hyperfluorescence, and when the ICG was done, the hypofluorescence, area of hypofluorescence exceeded the area of corresponding DFA. So that suggested that there was some ischemic choroidopathy there. This shows the USG of the left eye, which shows the optic nerve head edema, same suggestive as that from the MRI. Now this is the VEP. Now the VEP is very interesting as there was no any changes, there was no any problem in the latency. The only problem was in the P100, that amplitude was decreased. The EOG was nothing affected, means there was no RP affected. RP was not affected so much. Only the VEP was, the amplitude was affected, which signifies that there was axonal injury to the nerves, optic nerves. Now for that, we came to a provisional diagnosis that others were ruled out. It is a unilateral placoid disease, plus there was no causation of any systemic, any infective causes, and also there is no granular posterior uveitis causes also. So we went for this, and also it was not a chronic disease also. No signs of that, and no RP level was also not affected. So we had a provisional diagnosis of APM-PP with optic nerve head involvement. IV methylprednisolone was given for 5 days, followed by oral steroids. A drastic outcome came after that. 5 days after, the vision improved to 6/60. RAPT still persisted. After 2 weeks on oral steroids, the vision improved to 6/36. RAPT was reduced to grade 1, and after 1 month, it was 6/24 with no RAPT. So this was the automated perimetry. As soon as the vision came to normal, we show mild field changes in the left eye, and this was the picture at the end of 1 month. So only that mild optic nerve head thing was present and nothing else. So my take-home message is that APM-PP can rarely involve the optic nerve. Early steroid therapy improves prognosis, and close follow-up is very essential. Thank you.
Okay, that was a nice case. I had one doubt to ask. If you can go back to the FFA image, can you have the slides up, please? So, do you think APM-PP can lead to this amount of vision affection? And I can't see the late hyperfluorescence you said on the FFA. It seems to me that there is early hypo and also there is late hypo.
This one, Okay.
Yeah.
Yes. So this was the early hyperfluorescence part.
This is the right eye
Right
you are
eye,
referring
yes,
to. I
sir.
am referring to the left eye. Yeah.
Yeah, this is the early hyperfluorescence followed by late hyperfluorescence.
But you can still see that there are patches of late hypo that are there.
Yes, these are the patches of hyperfluorescence, both due to placoid and also choroidal ischemia, because APMPP causes the choroidal ischemia due to multiple causes. Vasculitis, there will be thrombotic events for after viral prodromes, and for that multiple things goes on.
Do you have
Choroidal
an,
ischemia is the main problem.
do you have an OCT scan through this?
I have not taken over here because there was not no such significant findings over the OCT, other than only that the choroidal swelling and RP swelling was there and nothing else.
Yeah, that is an important point. You can see on the OCT if the choroid is unaffected, then that makes the diagnosis of APMPP more likely. And also there will be patches of subretinal fluid. Wherever you are seeing hyperfluorescence, there will be subretinal fluid over there.
SRF
Right.
was not present.
So-
Only that the RP was little swollen. No SRF was present.
So that goes against APMPP. And what I feel is this is a case of posterior scleritis, and you should go through the ultrasound scans again. And because
Yes,
that also
there was
responds
no
beautifully.
posterior T sign. Yes, see. There were no posterior T signs also.
So what you can see here is a choroidal bulge is also there, where in the first ultrasound image, right, you can see that the RP, the retina is elevated, the choroid is also elevated, and there is a hypo sign underneath it. And just inferiorly, go even more inferior, where your A scan line is going through.
I can't find any fluidic area.
So when we talk about the T sign, that has to be seen around the optic nerve head. But otherwise also in the subtenon's space, there is fluid, and fluid
Yeah.
will appear as hypoechogenic. So if you have, you can go back and have a look at these scans again. So wherever there is fluid in the subtenon's space, it is not necessary that we have a T sign. The T sign will only happen when you have the optic nerve as well as the sclera around it. So this is more likely a case of posterior scleritis, and that can lead to such affection, especially when you have a FA that is more hypo and not
But,
hyper in the late stages.
But the VP and the VP findings were not collaborative with the posterior scleritis involvement with optic disc that happens, because only the amplitude was hampered, not the latency.
Yeah, so VEP, we are doing it to look at the optic nerve status. Here what we have is a scleral involvement. So that posterior scleral involvement can lead to optic nerve being involved secondarily. And that is why you had a good response with your steroids here. Thank you.
Thank you.
So we can go ahead to the next speaker. Dr. Rajvinder will be talking about post-operative hypotony after secondary IOLs. Can we have the slides up, please?
The topic of my presentation is post-operative hypotony after the secondary IOL. So it is a 52-year-old male laborer, and the chief complaint was diminution of vision in the right eye since cataract surgery 1 month ago. So patient was taken for that is secondary IOL, and at the outside he went cataract surgery for senile cataract in the right eye 1 month ago at an outside center, and there it was complicated by PCR and then converted to ECC. It was a large incision, and on a presentation to us the eye was aphakic and corneal wound was closed with interrupted 10-0 nylon sutures and referred for the secondary IOL. So vision in the right eye was that eye is aphakic, it was finger counting, and pressures were at this stage 13 and 15 mm in the other eye. And on the cornea, it was a large sutured wound present with the 10-0 sutures, nylon number 7 in number, and deep vitreous anterior chamber was deep, and there was vitreous was also there, and all the lens was that eye was aphakic. and on fundus examination, it showed no nuclear fibrillum, no cortical matter, and intraocular lens. So on that is the diagnosis is aphakia with the vitreous in the anterior chamber, and then it is at this stage the IOP is normal comparable to the other eye. Patient was taken for the right eye secondary IOL under local anesthesia under guarded visual prognosis. So I was so we can see here that there is a sufficient capsular sport. So I was thought of putting the secondary IOL in the sulcus, and ports were made, and after the vitrectomy, the intraocular lens was planned to 6 mm intraocular lens was taken. Actually, I thought of that if 6 mm won't go into the sulcus, then I may have to implant the scleral fixated IOL. So I have taken the scleral fixated IOL, and I have taken the help of the suture, so that if it is goes into the vitreous cavity, I can take it out with the help of the suture, but it fits well in the sulcus. And after that, stabilizing the intraocular lens in the sulcus, I did more of vitrectomy, and then the 10-0 sutures were placed. And the ports were not sutured, and as it is 23 gauge vitrectomy, ports were made, so they were left unsutured. So on the first post-op day, we can see that the vision was counting finger, and IOP in the right eye was 6 mm of mercury. And on OCT, when I was not expecting it actually, I was expecting the visual gain. But when I saw that the patient is counting finger and there is IOP is also low, then I for documentation purpose, I thought of recording with the OCT, and oral steroids were added. Steroid and antibiotic drops as usual we were given, cycloplegics were added, and patching was done, and patient was asked to patch the eye, and again followed up after 24 hours, and the IOP improves, and after 5 days we can see that the OCT we are not able to see the choroidal folds now. So on the post-op day, the vision improved to 6/9, and the IOP is also coming to the normal, and the patient was advised to taper the oral steroids as well as the cycloplegic agents. So there are chances where in these cases we can have a silent leak. So silent leak is a subclinical egress of aqueous humor, that is of aqueous humor through the surgical wound or the sclerotomy port that goes undetected on CDL testing. So in this case, the CDL was negative. So it does not produce the obvious wound gape or the sudden anterior chamber collapse, so that the eye may appear well formed. Leads to insidious drop in IOP and manifesting only as mild corneal and the shallow AC or the early choroidal folds. So they can be the various risk factors for silent leaks. That is high myopia, absence of tamponade, young age, poor tissue quality, vitreous-based dissection, prior vitrectomy, and intravitreal triamcinolone also. So the causes after vitrectomy can be the sutureless port leak sites and a poor wound construction or the tunnel. It may, so I have learned from this case. So whenever we have a large corneal wound, it is important we should, as a precaution, suture the scleral ports also to prevent such hypotony after the surgery. So the clinical clues to the hypotony are IOP less than 6 mm of the mercury, shallow anterior chamber, corneal striae or edema, choroidal folds, negative CDL test. So management is usually conservative, we can try the patching for 24 to 48 hours, surgical intervention if it is the CDL is positive, and supportive measures. So take home messages: large wounds and sutureless ports are risk key zones. So don't rely always on CDL test, and early detection is crucial to prevent the hypotony maculopathy. Early intervention, patching, suturing, tamponade can prevent the reverse hypotony related to maculopathy and prevent the permanent vision loss. Thank you.
Thank you for that great case presentation. So there can be other causes of such kind of post-op hypotony where there is no leakage. Cyclodialysis cleft can be one of them. So
Okay.
that usually responds well to our homatropine and atropine, and
Yes,
that
sir.
may be one of the other causes that we can do a UPMNC, but that is quite common during our secondary IOLs when we press more on the scleral lips.
Okay.
So it is kind of a small micro trauma that occurs, and as you said, the sclerotomy ports can be sutured if on table we find that the globe is a
Normally,
bit soft.
when we don't place any sutures on the cornea, they don't leak. We don't find any hypotony. But whenever there is corneal wound and we have resutured, sometimes we find such type of hypotony.
The on-table tone might be a bit less, and that might lead to the scleral fibers not getting realigned early. So it was a nice session. Thank you for that talk. And I can request all the speakers to come up, please, for a final photograph. Hey, you. Oh, sorry, we have one more talk, Dr. Manpreet Kaur. Yeah. So we have a chemotherapy-related endogenous endophthalmitis. I'm sorry for that. Yeah.
So, good afternoon, everyone. I have a case report on chemotherapy-related endogenous endophthalmitis. Coming straight to the case report, a 44-year-old woman presented to us. She had a hepatocellular carcinoma and presented to us with painless gradual deterioration of vision in her right eye for 2 weeks. The patient was non-diabetic, non-hypertensive, and she received 10 cycles of chemotherapy, atalizumab and bevacizumab, along with radiation therapy for chemo, for the hepatocellular carcinoma. Her last chemo session was 4 weeks back, and her best corrected Snellen visual acuity was counting finger 2 meter in the right eye and 6.6 in the left eye. Slit lamp examination of the right eye showed grade 1 AC cells and mild vitritis. On fundus examination of the right eye, there was a yellowish white focus resembling subretinal abscess over the macula with normal retinal vessels and disc. Left eye fundus was absolutely normal. IOP was normal in both the eyes. We did OCT, and to our surprise, in the right eye, it showed a hyperreflective area in the inner retinal layers in the foveal region. So this is the right eye fundus picture. The optic disc, the vessels, and the periphery were absolutely normal with a single foci in the macular region. This is the OCT picture. We can appreciate the hyperreflectivity in the inner retinal layers. So we did complete systemic examination including CBC, DLC, which revealed mild neutrophilia. QH examination of the vitreous tap was done that showed a few fungal hyphae, whereas the gram stain was absolutely normal. And a vitreous tap was taken and sent for culture. Blood culture for bacterial and fungal growth were negative. On the basis of QH examination, we give intravitreal vancomycin 1 mg per 0.1 ml, ceftazidime 2.25 mg per 0.1 ml, and voriconazole 100 mg per 0.1 ml in the right eye. Patient was put on oral tablet itraconazole 100 mg twice a day for 14 days after the oncology opinion, and topical antibacterial and antifungals were administered. After 2 days, the vision improved to finger counting 4 meter from finger counting 2 meter. And on fundus examination, there was a significant reduction in the size of the subretinal abscess. We did repeat OCT, which showed a reduction in the size of the hyperreflective material over the macular region. Intravitreal voriconazole was repeated 2 days after the initial dose, along with vancomycin and ceftazidime to take care of the bacterial infection as well. Vision, fundus examination, and OCT were done after every 2 days, which showed marked improvement. After 10 days, her vision improved to 6/9. AC cells and vitritis were completely resolved. The left eye was examined on every follow-up visit. After 4 weeks, the vitreous culture examination came out to be positive for Candida species. So this is 10 days after the initial dose of vancomycin, ceftazidime, and voriconazole. This is the OCT finding of the right eye. There is reduction in the hyperreflective material in this. So coming to the discussion, this case report describes a case of fungal endogenous ENDOF in the context of intravenous chemotherapy. Risk factors for endogenous ENDOF in this case are compromised immune system and the use of IV catheters for chemotherapy. Among bacterial, gram-positive, staph and strep2 are the most common causative agents in the Western countries, whereas in Asian ones, Klebsiella is the most common organism. Among fungus, Candida albicans is the most common cause of fungal endophthalmitis. In this case report, the culture was positive for Candida. So endogenous endof is mostly unilateral, but 1/3 of cases can have bilateral involvement as well. The infectious agent travels through the bloodstream and multiplies in the choroid, eventually infiltrating the retina and spreading into the vitreous. The organism spreads through the internal ocular tissue through the blood-ocular barrier. So the take-home message, it is an ocular emergency and any suspected patient should be treated promptly. Assessing the extent of ocular involvement, identifying the causative organism and the underlying source of infection, and treating both the endof and the underlying systemic infection are the steps in the care of such a patient. In high-risk individuals, an early diagnosis of endogenous endof could avert irreversible vision loss. Thank you so much.
Thank you for that interesting case. And as the last one, you get the golden question to be asked. How frequently do you repeat this voriconazole intravitreal injections?
So not in every patient, but depending upon the duration of symptoms.
No, I'm asking per patient. How frequently would you re-inject the voriconazole?
After 48 hours.
After 48 hours?
Yes.
And do you know what is the half-life of voriconazole in the vitreous?
Not exactly.
So you can look that up because there is another agent.
One second.
Yeah.
I'll repeat the injection twice. But even after the second injection, the patient is not improving, then I'll go for vitrectomy straightforward.
Yeah, that is about the repetition. So the important thing to remember is voriconazole has a shorter half-life, about 8 hours or so. Okay. So you might need to repeat it every day, and in some patients initially twice a day also.
All right.
So amphotericin B is another option which lasts longer, and it also works well for other fungal species, right? Thank you for that case presentation. If we have no more doubts, we can wrap up the session with the final photograph. All the speakers can come up to the dais, please.